Welcome back to Rural Health Today, our latest series, Rural Health Fractured. In this series, we're discussing how rural health is being fractured in nearly every direction by the politicization of health and science, the decline of resources for rural communities, access to adequate insurance coverage, and so much more. As we take a closer look at the fault lines in our healthcare system, our guests will provide new perspectives on how healthcare leaders can navigate these challenges and explore sustainable solutions. Welcome back to Rural Health Today, our latest series, Rural Health Fractured. Now, that's a new series for us, and I'm excited to talk a little bit about how our rural health system is fractured in this country. We're taking it piece by piece, and we're going to talk today something very, very important, which is nursing and some of the challenges that we face in our rural communities as it relates to nursing. But what we see is a politicization of health and science, decline of resources for rural communities, a deterioration of adequate insurance coverage. We're hearing more and more about that, and so much more that is really impacting this discussion. We'll take a closer look at the fault lines in our healthcare system, and our guests, like ours today, will give new perspective on how healthcare leaders can navigate these challenges and explore sustainable solutions. So I'm delighted to be in the studio for the second time, but for the first time by yourself, a good friend of mine and a friend of Michigan Hospitals, Amy Brown, a nurse by trade, but also the chief nursing officer, a new role at the Michigan Health and Hospital Association, also known as MHA. Amy, it is great to have you in the studio again. You were here, how long's it been? 2 years ago?
I had been in my role for just a very short time.
A few weeks. And you've been at MHA for how long?
It'll be 2 years in May.
All right, so shortly after you arrive at MHA, you're visiting a plethora of hospitals, and you get to Hillsdale. We had a chance to talk. Then you were brand new.
Yep.
Probably the position description had not even been defined yet, I would assume. But it's great to have you in the studio. For those who may not know you or remember you from several years ago, why don't you give us a little history of your background, where you come from, where you went to school, and what are you doing now at the MHA?
Sure. Well, thank you for having me.
Absolutely.
It's a pleasure to be here, and especially talking about rural health. But so I actually grew up in a rural setting. I grew up in Potterville, Michigan, Charlotte, Michigan.
Absolutely.
Went to high school there, and then I went to Grand Valley.
Yeah.
I became a nurse there. I started working as a med-surg nurse.
Mm-hmm.
I was fortunate enough to get a day shift position on a med-surg unit. It was a 40-bed unit, and we took care of everything.
Okay, so a larger hospital.
It was 150 beds,
okay,
200 beds.
All right, decent size.
Yeah. But the way it was a typical med-surg where it wasn't, you had to know everything because you
see it all.
One day you were taking care of total joints, the next day you were taking care of surgical patients. So did that, and then I transitioned, moved back closer to home to raise my kids, and I wanted them to be around their grandparents.
Yeah.
And I started working at a large hospital, 500-plus bed hospital, and started I was a nurse educator, manager, director, vice president, and then on March 18th of 2020 in a parking lot, I became the chief nursing officer.
In the parking lot. In what year was it?
2020.
2020, a very interesting time, right? So you labored through the pandemic.
I did,
right?
for 3.5 years.
3.5 years.
And then this opportunity came.
And let's go back to that. You were the chief then at that time? So the chief.
Yep.
Employees, give us a perspective. How many employees did you have working for you roughly at
Over
that time?
1,000 nurses.
Over 1,000 nurses. So you know what the challenges are of nurse recruitment, which we'll talk about in just a minute. So over 1,000, deal with the pandemic, see things we've never seen before in our lives, right?
Yes.
And then you get out of the pandemic and you're asking yourself, what am I doing next? Is that what happened?
Yes.
All right.
Yeah.
Did you ever think about MHA before that?
No. Well, I came in contact with MHA because honestly, I was frustrated because I didn't see a lot what they were doing with nurses.
Yeah.
They were interacting with a lot of CMOs, especially during the pandemic, and not as and with CEOs. Mm-hmm. But I didn't really see the relationship with nursing, and so I talked to my good friend Lindsay. And said, I think there's an opportunity, and so we started a statewide CNO call. When I was still a CNO at a hospital, and did that for a while, and so.
So you're still in your role as a chief, and
yep.
you're leading the state initiative.
Yep.
for nursing and kind of like the flavor of that, huh?
Yeah. And Brian Peters, was very receptive to it. He's like, yeah, we should interact with nurses. And so he supported it.
Yeah.
And so, MHA, I think, really felt with that we were missing a key workforce, the voice of nursing. And so I think obviously they felt enough that they created a position, a chief nursing officer.
Yeah.
And that's very rare for state associations. They often have one or two nurses working at state associations, but not typically in that chief nurse role.
So tell me, how did it lead to that? I mean, so you're around a table, you're having discussions about, obviously I heard your name because I'm on the board, and I did learn about some of the work that you were doing before we hired you. And certainly, you were doing some great things to convene a group of nursing leaders to talk about some of the challenges that Michigan hospitals were facing. But at what point did you say, I want to change a different pathway? And
well, they changed my mind for me.
Okay.
I was asked to step down.
Yeah.
So it was something that I didn't foresee.
Yeah.
And it was kind of forced upon me that, I was no longer in that role.
Yeah. And that happens. This is what we deal with in corporate America, right? I mean, it's you get through a major pandemic and then all of a sudden there's a reorganization, there's new leadership. And so that's very common. But I mean, to make the transition though from the chief running, everyday nursing units to more, and don't take offense to this, but more administrative in nature now.
Yeah.
I'm sure when you were the chief, you probably went and took care of patients, right?
I did.
Knowing your personality.
Yeah.
And so that's different for you now, right?
Very different. And honestly, that I love my job at MHA, but when I just spoke with a nurse manager that I hired a long time ago, she called me, and she's a CNO now in Pennsylvania.
Nice. Isn't it great to see that transition?
I loved it.
You were part of it.
Yeah. And she was telling me some things that she's been implementing and all the things, the great work that she's doing. Yeah. And as soon as I got off the phone, I thought, I missed that.
Yeah, exactly. But not too much, right?
No.
Okay, good.
Not
good.
the 2 a.m. phone calls.
The 3 o'clock nursing, calling in sick and the
staffing,
flu and staffing issues. So let's talk a little bit about what your current day looks like.
Yep.
Because advocacy for nursing is so important. There is a fine line because there are unions that drive certain elements of this in bigger hospitals. And there are a lot of hospitals that don't have unions. So, to have an advocate is very important. But tell us about the work that you do at MHA every day. What does that look like? So
my role has changed a little bit. So I was hired on as the chief nurse, and my primary role was really to go out and interact with nurses, convene nurse leaders, collaborate, share best practices. And then probably right after I did this podcast, we decided MHA made a little bit of a change, and we decided that the quality and safety arm, or the Keystone Center, would be led by myself and Dr. Gary Roth.
Right. Have you ever participated in Keystone when you were in your chief role?
Not as much. Yeah. I did with some of the age-friendly, but I didn't work in critical care, so the early work I wasn't as familiar with. But some of the other stuff I do remember.
Yeah. So Sam comes to you and says, "Hey, Amy, I got an opportunity for you."
Right.
And now that's a heavy lift. Because that's a huge program for us at the MHA.
And so, but I was really excited because I felt like that would kind of bring me more of the clinical route, really looking at some of the projects that they're working on. Yeah. So that was really exciting. So I kind of shifted. I was doing the CNO work with regards to visiting hospitals and engaging with nurse leaders. But then I was also really looking at our patient safety organization, the quality work. So day to day, I think it's probably, I spend a lot of time still. I am still visiting with hospitals. I have not made it to every hospital in the state of Michigan.
Yeah. Well, there's quite a few, so it takes a while.
Yeah, it does.
And How far have you gotten up north, though?
I've gotten very far up north. Yeah. In fact, I was in Houghton in August. I always
good
pick
time
August.
of year to go versus December or January.
And then I also try to, if there's a new CNO, I try to meet with them. Yeah. And as you know, as CEOs change over, so do CNOs.
Oh, absolutely. So very common.
Some hospitals I've visited more than once because I go back to meet with the new CNO.
Sure. Yeah, important. So currently, your day-to-day job is diverse and advocating for nursing, but working with our chief clinical officials, whether it's a nurse or in some cases they even have physicians that serve in those capacities. But before we dive a little deeper into the interview, our listeners don't know maybe who you are as a person. I do. But do you have a fun fact about yourself that would really humanize you to this podcast?
Well, I don't know if it would humanize me or if people would think I was crazy, but
well, it's still going to humanize.
So I'll give you a little bit of perspective. So I wasn't big into sports. I liked playing sports, but my mom said I could do one or the other. I could either do sports or I could do tap dance.
Oh.
And I said, I want to do dance.
Yeah.
So I had to pick.
Yeah.
So I'm a tapper.
Is that right?
Yes.
Still
and,
to this day?
Well, so the
rest of the story.
I really, I haven't tapped in a long time.
Okay.
But I pretend often like I have tap shoes on and I'm dancing throughout the house.
Nice.
And so for Christmas, my family said, what do you want? And I said, I would love a pair of tap shoes. And they're like, Mom, we are not getting you tap shoes. My new son-in-law got me a pair of tap shoes. No.
So he really wanted to get on your good side.
He did.
But did he get on the bad side of everybody else?
Well, yeah, his father-in-law
wasn't wanting tap shoes.
No, we were in the basement cleaning up, and I said, I'm going to put these on with the cement floor.
No, you didn't.
And so as we were cleaning, I was tapping along, and he didn't
appreciate it as much. Yeah. Well, that's a great story. Yeah. And certainly it's great to see that aspect. You can have fun.
Yes.
And we've lost a little bit of that in our careers. And I want to talk about that in a minute because there's a lot of things that are impacting healthcare today. And among those are violence in the workplace. I want to get to that in just a minute and really have a dialogue about that. But it's great to have you on the podcast today. I'm excited. And I really want to highlight that in this episode, we'll focus on workplace violence and healthcare settings, that impact that it has on the organizations, on care teams, how they deliver their care, how they come in prepared for that care. And I'm going to ask that our guest today, Amy, share her perspective on how rural health has been fractured by violent actions against healthcare staff, who are truly the heart of every healthcare system, our nursing staff. That's where it's at. If you don't have nurses, we're not going to have hospitals. So we'll talk about how that relates to even burnout, how it relates to, the relationship with peers, resources that we can look at that hospitals can deploy as a result of how do we respond to the violence, and then what all this has to do with rural health. So once again, it's great to have you in the studio. I want to start it by setting the scene of kind of what we're dealing with today in healthcare, and specifically as it relates to healthcare violence, because there's been a huge initiative by the MHA to promote safety in the workplace. And I remember the posters we put up. I don't know if you were part of that several years ago, that, every marketing, I think, team member in hospitals across the state were in the ER putting up posters that talked about violence and anti-violence against healthcare workers. So talk to us a little bit about what is the state of violence in healthcare settings today. And I guess let's get to the heart of the issue. Why is that violence occurring in those healthcare settings, and what can community members do to help us with healing? There's a lot that can be done here. So let's start by setting the stage. What is going on?
So I can tell you, I've been a nurse for 24 years. Prior to that, I worked in a brain injury home, and it was similar to a rural setting because we had limited resources. We didn't have security. We relied on police. We didn't have a lot of staff. It was the evening time. And just thinking about this, my stomach is turning and my hands start to sweat because I had a patient who attacked me. And I had to lock myself in a room.
Oh, my goodness.
And when he finally got through the door, it was me in a partition. And he punched the partition so hard that it knocked over. And I really thought he was going to harm me while we called 911.
Yeah.
And we waited for someone to come. And
right.
Because we didn't know how to put hands on patients.
Yeah, I mean,
we didn't know how to
you're not
control
learning,
that.
Right.
But unfortunately, it's still happening in all settings. And as in my leadership roles, I often, even as a manager on the unit, I would always be de-escalating. And I think when I think about describing that my hair's been pulled, I've had bruises, I've been punched, I've been spit at, I've been sworn at so much.
Oh, yeah.
It sounds like my job's at a bar, right? But it was in a hospital.
Yeah, and that should not be an occupation hazard in healthcare.
Right.
But it's become one.
And I, to this day, it's something that I've been very passionate about. And I've always said, I really want to try to fix this. And I have a 20-year-old daughter. And about 3 years ago, she said that she wanted to be a nurse. And I said, oh, great. And when people would ask me, why do you want, why are you so passionate? I said, because I have both of my girls. I have a 22-year-old who wants to be a doctor. Both of them are going to go into healthcare. I want to make it safer for them. And it makes me sad. It makes me excited because we still have a lot of work to do. It makes me a little sad that we're still talking about this.
We are, yeah.
And it keeps changing, right?
Yeah.
But
how would you describe the state today of what we're facing?
I feel like we're chasing something and we can't catch it. We keep trying different things, which is great. And actually, I'm part of a committee. It's Lawrence Tech University. And we work with them, MHA does, and a couple hospitals are partnering with them as well. And I just talked to, he's the director of security, and he went through a whole list of all the things that they're deploying. And thankfully, they have a lot of resources. But out of all that whole list, he said, my violence has increased. So you would think if you were putting all those resources towards something, that you'd be seeing a decline. And he's still having that violence. So I think there's a lot more to the problem, and I think it's really hard. So I think that I'm not giving up. We need to keep working on it. But I think right now what we're seeing is we're seeing communities that need help, and they're not getting that help. But hospitals are always open.
Right.
So they keep coming back to the hospitals.
Right. Yeah, just this week I have monthly what's called Presence Exchange, and a member from every department that they nominate and delegate will meet with me in a group setting with all the other department representatives. And I go through every month, how the organization is doing financially, all of our pillars, people, service, quality, growth, finance, and talk about, what the state of healthcare is. Every meeting, the issue of workplace violence is brought up. Every meeting, just yesterday again. JJ, when are we getting more security? JJ, what are we doing to address this? JJ, did you hear about the incident that happened in Coldwater 2 weeks ago? It's heavy on the minds.
Yes.
And it impacts psyche. It impacts individuals' ability when they know they have a patient that may be boarded for several days. Even impacts their ability to want to come in and work. See call-ins, sick time because of management of that patient. But I want to go back a little bit and talk about what are our universities and schools doing to address this. And are we educating our future nurses about these dangers? And, there's new de-escalation, techniques that hospitals have deployed. You hear about it all the time. Talk to us a little bit about some of the work that's being done in that area.
So unfortunately, I have to say, not a lot. I think I just talked, the Keystone Board, we chose workplace violence or worker safety. We chose that to really, we want to work on that. And we just had a board meeting and I reported that. Unfortunately, what I'm hearing from students is they're not getting any education. And so I keep thinking
That's a challenge.
It's easy to look through things when your kids are going through things. And so my daughter, who's in nursing school now, she, on her first day of clinicals, the nurses assigned her a patient who was violent. So, they're not really thinking about it. I think they're a little numb to it.
Right. Well, probably to the point where they're dealing with it daily, right? So it's just assumed.
And so she went into this room and she was scared. And some of her classmates, so then 8 of them, they go back and they talk about this. And so now it didn't just impact one nurse, it impacted 8 of these nursing students. She said one of her friends has already said, for one, I don't want to be a med-surg nurse, which that's where we need nurses right now.
That's a training ground of nurses.
And 2, she said, I don't even know if I want to be a nurse.
Yeah, that's a problem.
So when you think about the pipeline, it's impacting the pipeline. And we have to be careful because if we talk about it too much, I don't want it to deter people from going into healthcare.
But there needs to be awareness.
Yes. And so I think we have a great opportunity. And so I've been talking to MHA. What if we piloted working with, what the schools have said to me is that it's really hard because their timelines of instruction are so tight.
They are. They have to get
And
through
so
the
where are they
quickums.
going to?
Everybody wants to get through quicker.
Yes.
And so how are you going to fit it in, right?
How are you going to fit it in?
Yeah.
Are you going to count it as a clinical? Are you going to make them do it on their off time? Now, my daughter said, if you can get a class for us for de-escalation, she said her and her friends would come to it.
They would, absolutely. We hear that often. So let's talk about, in a hospital setting, there's high-risk areas. We know that the emergency department is a high-risk area. We know that psychiatric inpatient is a high-risk area. And at times, even our skilled nursing facilities, we have all three of those here, can be high-risk, combative individual who may have dementia. In a dementia unit, that's a challenge. Individuals who have psychiatric backgrounds who are struggling and have behavioral issues could lash out at our techs and our nurses. And then the ER, you just never know what you're getting in.
Right.
Especially with in our facility, 20,000 individuals walking through the ER annually. Bigger facilities triple, quadruple that, right? You just never know what's coming in the ER. And I'm sure you supervised ERs as a chief. That is where some of the most volatile places are. So, how do we address those high risk areas? And is there a focus MHA has put on in educating the community, the patient? There should be an ownership on patients too, right?
Yes.
They should know that there's some challenges, that if they act out, I believe the Attorney General's even prosecuted, and there's been some laws. And let's talk a little bit about that. High risk units, why are those most vulnerable for attack compared to lower risk areas? And then what are we doing to address it?
So I think one of the things that MHA is really trying to address it a couple different ways.
Sure.
So one is the training. Yeah. So we have a lot of different opportunities. We work with different vendors. We realize that it can be very costly. So we've actually paid for some training for hospitals. We've done anything from de-escalation to active shooter drills. Yeah. And the one thing I would say about active shooter is it's a very low occurrence. Yeah. But the way that I've shared it with others is that if you asked anyone from my generation about tornado drills, and hardwired, it's right. And so when I think about this generation, my kids' generation, they grew up doing active shooter drills.
Sure, they did. Sure.
So that's one of the things where I think hospitals need to understand that if you don't do any type of active shooter drill in these kids' experience, they're thinking you don't care about me.
Oh, right. Right.
So I think that's something that's really, it can be done at a very low cost. Yeah. But most of the violence that we deal with is from our patients.
They are.
And so there's the de-escalation training is what I've found to be, I don't have the research to prove it, but the way that I see it is it's kind of like a code. So when you have a code, a patient that needs emergency help, you have a code team. And that code team is very well trained. They know how to respond, and then others know how to respond until either the code team comes or, especially in rural health, right? You're sometimes reliant on the emergency physician or something like that. But the more you train, it's like muscle memory. The better you are at it. Right. And there's a lot of, when you look at med surg in those high areas that we talked about, ED, there's a lot of new nurses in those areas.
It's it's where they start, right? In many cases now, it used to be the tenured nurses are going to be in the OB and ERs, but because of the turnover and what we see with our talent pipeline, they're all new.
They're all new. And so how do it can't be one and done. Yeah. I think it's something that is going to be like, and even with CPR, they found it used to be you get recertified every 2 years. The research shows that there's programs out there now that have these simulations where you do it every 3 months.
Oh, sure.
And so I think that's the same thing with de-escalation. You can't just do it once and expect for it to stick. The other thing that MHA and Keystone is doing is when you think about after you've participated in this type of horrible incident, how do you recover? How do you come back to work?
That's a great question.
And so we have something called the Well-Be Results.
Okay.
And it's a free resource. It's on the website, and I have information that I can share. Yeah. And it's really webinars, so it's not in person, but the research has shown that if you commit the time to going through some of these scenarios, that you are more resilient and you are able to come back to work. Yeah. The other thing is, I think for us to think about is what is your response in your local hospitals to interact with those people? what I found is some people get injured and they go off of work. And, it was always like if the person's off work, then they're, you don't contact them.
Correct.
You don't,
Oh, yeah.
So
all
you
the
have
rules
this,
apply.
right, HR rules. You have this person at home
Yeah.
who feels like no one cares about me.
Yeah, they're out of the loop.
No one's checking on me.
Yeah.
And what we found with a particular caregiver is they were going to press charges. So the police said, okay, come back to the hospital. So we asked them to come back to where it happened.
Correct.
Alone.
Yeah.
The police didn't notify us. We didn't notify the caregiver. So they had to come back to the hospital, interact with the police officer all by themselves in a public setting.
Yeah.
It was very traumatic for them. And so I think that we still have a lot of work to do with regards to how do we can't prevent every incident from occurring, but how do we support and really wrap our arms around? And that's where I see when you think about the limitations of rural health, you can't have security officers everywhere because it's very costly. You can't have metal detectors everywhere. What you can do is you can have those wraparound services. You yourself, I know what a caring individual you are. I know all the things that you do for your community. I think that's where rural health is. You support that person and help them come back to work.
Yeah.
And that's where I feel like, to me, it's how you make the person feel safe when they come back to work.
So, trust.
Yes.
It's an important word, right? And to your point, very well articulated that oftentimes when there's an injury at the workplace, we go down the HR track. And I would encourage our listeners today to look at this differently, from a different lens. Yeah, there's an HR process, but you cannot get stuck in that, because then what you're told is no nurse leader can contact their employee. You cannot have communication. And that's a challenge, because sitting at home for 24 hours a day while you're injured is almost like, have I been abandoned?
Yes.
So I'm going to ask you, hospitals are listening today who are going through this. We just went through it not too long ago. What advice would you give them about how to restore that trust? How do you get that person back to this holistic understanding of we're going to take care of you, when we just put them through an HR track where they cannot call us, they can't talk to us, they can't do any of this? How do we do that?
Yeah.
Give us some advice, because there are hospitals asking that question right now.
So I can tell you what I did is
That's what we want.
I contacted the person.
Okay,
I
good.
called them and
Good.
left a message.
Good.
And all I said was, it might have sounded intimidating, because I even did it when I was a CNO and said, I just want to check on you. You don't have to call me back. I just want to leave this message and let you know that we're thinking about you.
Good.
And here's the number to this individual in HR.
Yeah.
Because I didn't want them to feel like they needed to contact me if there was some type of health information. But I think, and I think we can't let the rules dictate. They're humans.
Absolutely agree.
And they have feelings.
That's right.
And I think that could be the bridge between them not coming back or coming back.
Yeah, I agree with you. Do we have any, and I'm not going to put you on the spot, so maybe it'll turn into some homework, but do we have any statistics around what percentage of nurses or techs or whoever's injured return to work after an incident?
The research that I've seen is it's very hard to track, because, for instance, in my past experience, they would come back to work, but they would come back in a different area.
Right.
So they wouldn't leave the
Different
hospital.
position.
Yes.
So they're still employed, but not in their original capacity.
Now
or they drop down their status.
Right. There are
things.
some statistics where they just leave nursing altogether.
Yeah, I hear that. That is an issue.
And it's usually typically in that first, 1 to 2 years of practice. And then I think there's obviously probably places that just leave and go to an outpatient setting. However, even outpatient settings now, that's one thing that we haven't really talked about. And they need this de-escalation training, I think.
Absolutely.
Just as much as the inpatient does.
Absolutely. It needs to be equal. So let's transition to, what does all this have to do with rural health? Because in rural hospitals, we don't have a major security force, right? Can't afford too many cameras, right? Cameras don't save lives. People do. A lot of challenges around rural right now. So what recommendation would you give? You worked at a rural hospital of sorts, 150 beds, smaller hospital.
Yeah.
Those hospitals do not have full-time forces. They, struggle. They have maybe some internal teams. But what recommendations could you give to the rural hospital saying, how do we deal with this? Because it's impacting our recruitment, it's impacting our retention. How do we address violence? Where does it start? And then what tools can we deploy as a very poor, zero margin rural hospital?
So, I think I've been thinking about this a lot when I've been visiting rural hospitals.
Yeah.
And I make a point to go to rural hospitals because they really tell the story. And oftentimes when I ask to come visit, people always, say, well, what do you want to see?
What do you want to see?
And I say, I'm very visual. And
Yeah.
even when I go to advocacy and do advocacy work, I always tell them that it helps me to be in your space,
Right.
to see what's around and to kind of meet them where they are. And when I was in Schoolcraft, when they were describing a very, very small, very isolated area in the Upper Peninsula, it gave me great perspective. Even driving here, my cell phone cut out multiple times.
Yeah, yeah.
So I think when I think about rural health, I do think that there's differences. One of the things that I read in this article, it's called National Rural Health Association.
Yeah.
And one of the things that they said in this article is that the other tricky thing about violence in the workplace in rural health is oftentimes they're small-knit communities.
They are.
And so you might have a violent incident.
Yeah.
That's your neighbor.
That's your neighbor.
And
person you
now,
went to church with.
Are you going to press charges against
Yeah,
them? Are you going
exactly.
to? And so I think that's definitely something that affects rural health differently than
Yeah.
it does a
Yeah.
bigger hospital. But I think there are things that you can do. Some of them is enhancing the safety training. So from a financial perspective, you do have to most of the times pay people for training. So
Sure,
it would be
sure.
that type of a
Right.
cost. I think the other thing is, and I'm sure you already do this, you would be awesome at this, is community awareness campaign. So really thinking about how you engage your community,
Right.
because when you go to some boards, they have no idea that this is happening. So just the fact of we're doing this podcast will be great for the communities to know that nurses are injured,
Yeah.
healthcare workers are injured, not
Right.
just nurses.
Right.
Collaboration with law enforcement. You might have a little
Yeah.
in with them there.
Yeah, a little bit.
But I think, so for instance, my example previously when this police officer came in and was interviewing this nurse in the lobby,
Yeah.
just in front of everyone. But that's just what they do, right?
It's what they're trained to do,
That's
right?
what, they
Yeah.
interview someone on the side of the
Absolutely.
road.
Absolutely.
But what they might not understand is that
Yeah.
that's very vulnerable for this person to be
Right.
in this open setting.
So in your opinion, who owns that? Should that be the chief executive saying nursing or a supervisor saying, "Hey, let's find a private area"?
I think it's a
because the
process.
police officer is just thinking, get the report,
Yep.
get the incident, find the bad guy, make the arrest, do those things, not really thinking about the environment,
Yeah.
right, of where we are.
I feel like that's where a CEO, a CNO, all
Yeah.
those people in charge can help develop the
advocate.
protocol.
Yeah.
Like say, okay, here's the protocol. And then that's where we work with our law enforcement to say, hey, when you come to the hospital, call this number and we can help you.
Absolutely.
So I think that's one thing.
That's one area.
The resource allocation, I think that's something that we need to continue to talk about with our, when we think about deploying resources,
Yeah.
how do we look at utilizing technology
Yeah.
for rural health? And there's a lot of different ways that you
There
can do
are
that.
a tremendous amount of,
But again,
it's costly.
you don't have, $1 million to
That's
put
right.
towards something.
That's right. I understand there's new technology at Henry Ford hospitals of gun detection when you walk in the doors. And it somehow detects the firearm as you walk through. But that type of technology is hundreds of thousands, if not millions of dollars. So I think what you're getting at, what I'm hearing is it's just human intervention, awareness, education.
Yep.
It's important to educate the community, is what you told us.
Yep.
That's an important aspect of it. And there should be an absolutely stop measure here that you can't harm healthcare workers.
Right.
And if you're going to harm healthcare workers, you're going to be held accountable.
Yeah.
And I do know that the Attorney General has taken a stand against violence in healthcare settings, prosecuting people for violence-specific measures in the state legislature that have come in for that. I think those are all important steps, right, in educating the community about we're not going to tolerate that.
Right. And MHA has done a lot with regards
Yes,
to advocacy, and
very
we have a
much so.
new bill that and I don't know the number of it, but that's something that we're looking at because we have certain laws out there, but they still are very protective for behavioral health patients. And this new language would help so that it would still hold behavioral health patients responsible, but we would still understand that while they're ill, they need to get help. We're not going to put them in jail.
Absolutely.
That's not going to help solve the problem.
Place,
We need to get them the help that they need. But there are some behavioral health patients who are aware of what they're doing, and they are still choosing to act out.
Absolutely.
So for those patients, we need to hold them accountable. But I think the thing that I would say is that making sure that people understand that it is going to happen. How are we going to really wrap our arms around that person? I think to me, that's the retention piece.
Amy, are you hearing when you go about your journeys at various hospitals, are you hearing that the departure rate for nurses, that there's a link between what's happening and violence? Or is that a serious issue? Are you hearing it's an underlying problem? Is it a major issue, small issue?
I think it's a big issue.
It's a big issue.
I do.
And how about for the talent pipeline? Is it a detriment to people applying for nursing scholarships?
I think that, just thinking about my own experience with my own child and their class, none of them want to work in med-surg. And a lot of it has to do because, and it's not just violence, it's the way they're treated. And nurses are very bad at setting boundaries. So you might have a violent patient, and instead of saying, you are safe, I'm going to leave, they stand there and they listen to someone berate them and swing at them. And so that's another thing of an education piece where we need to help our healthcare team set boundaries. So to say, until you can talk to me in a kind way, I'm going to leave.
I'm going to leave, right? So last question, because hard to believe it's been like 40 minutes. We're out of time. But I want to ask you, what actionable steps you're a chief nursing officer. What actionable steps, let's say all the chief nursing officers in the world are listening to this, what actionable steps can they take? Because there is a balance between going to HR, advocating at administration meetings, going back to your nurses to empower them and tell them we support you. How do your chief nursing officers build that trust in their nursing? What advice would you give them? Is it fireside chats? Is it management by walking around? How do we change this idea that nursing is a bad place to be because of the violence? How can chief nursing officers get through this?
I think that's a big question, but let me try to answer
question.
I think one of the first things I would say is go to the people. And tell them what you're doing. Because I don't think they always know.
And we don't always tell them, right? Because we're doing it in the background.
So I think that's the first thing is make sure you're rounding. The way I like to do it is I would round on the units. I tried to do some of the big groups and people aren't as open as if I would just walk around and say, hey, do you have just 5 minutes?
Absolutely.
So that was something I think that you should continue to do is make sure you share with them, here's all the things that we're doing, but what more could we do to make you feel safe? I think by just saying, here's what we're doing, it shuts them down. I think asking them the question, what else would you like us to see?
It gives them empowerment.
And I think also being able to say, I would love to be able to have metal detectors, but that's just not going to happen.
It's not doable.
And it's not going to prevent the patients from. So I think.
But maybe could we change the language? So I hear that here. Let's get metal detectors. And I'll say, okay, and they're good to what degree? The security officer, which we do have, we're blessed, is upstairs in the psych unit dealing with an issue. What happens when the person walks through the metal detectors and it goes off? And there's no security around, right? They just keep walking. Do we assume that they have something? There's a lot of work into that. But I think it's important how we communicate the no. Because we can't just say, no, can't afford that. That's ridiculous. We have to say the why. Like, you know what? We have other technologies that we've deployed or resources or education, correct?
Yes, and that's what I would say is start with what you can do. You can do education. There are de-escalation. There could even be grants out there to pay for de-escalation training.
I mean, you look at Michigan Works has the state funding that goes for workforce development and those things. We get hundreds of thousands of dollars a year, and you can prioritize it to workplace safety.
The other thing I think is looking at your incidents, where is it occurring, and focus on those areas. Like we talked about med-surg, ED. So I think education, and then also I would say is making sure, and I know I've said this multiple times, what are you doing with the information? So when you know that someone was injured or someone was screamed at, what are you doing with that information? How are you sharing it with your board? How are you circling back to the person? How are you circling back to the team? Because the team might have witnessed something to say, hey, here's what we're doing. And I think the more transparent we can be, I think people want to know that you care about them.
Right.
People want to know that, do you know that this happened to me? And what are you going to do about it so that I can keep coming back to work? And so I would say is really that's where you need to spend your time, energy, and resources.
Agree with you. Amy Brown, Chief Nursing Officer, Michigan Hospital Association. You've given such a great perspective today over a variety of issues, talent pipeline, nurse recruitment, and what that all has to do with safety and how safety plays a key role in. If someone is listening today and they want more information about this, can you direct them is it MHA.org? How can they get additional information, at least in the state of Michigan? And outside the state of Michigan, I guess we'd encourage them to go to their, this is a national podcast, go to their state association, would you recommend? So give us some resources.
Yeah, so you can definitely find more resources or more assistance going to MHA.org. The Keystone Center tab has specific things about the well-being program, some of the other things that we're working on. Honestly, I welcome anyone to email me, abrown@mha.org. And
we'll put that in the show notes as well.
That sometimes I find that just these little conversations can kind of spark something.
Yeah.
And I would say is ask questions. Yeah. When you are if you're listening to this, talk to your leaders and say, hey, what are we doing?
Right.
How do we support someone who's been a victim of violence?
Right. It's a great, empower them.
Yeah.
Yeah. So Amy, last question of the day.
Okay.
And it's a new segment that we launched with this podcast called Rural Health Recommendations. And we ask each of our guests, and you have a lot of experience in healthcare, and you have a lot of sage advice. And so someone who's listening to this, maybe in Oregon, is just starting their role as a CNO or as a C-suite leader. We want to empower them, and we have a little segment, Rural Health Recommendations, that really gives a short introduction of here is how I would recommend you to, make it through these very difficult times. So what sage advice would you give a new leader today? It may not even have to be rural, but that's typically what this focus is, about how to make it today. And do you have any good advice that you could give them, sage wisdom about what you've experienced, about how to stay the course? There's a lot of challenges. One big, beautiful bill is impacting how hospitals get paid. That's impacting the ability to give raises, hire people. All of these things are compounding. And you have nurse leaders who are trying to do it on a shoestring budget and hiring staff. At times, they don't have enough. What sage advice would you give a new leader today of how to make it?
What I would say is, despite all of the complexities of healthcare and everything that's compounding and coming down, and it feels like it's just never going to get better, I always would go back to the patient. Mm-hmm. And, when I worked in a hospital and I felt overwhelmed, I had a budget that was due, I had this, I honestly would close my computer and I would go round on a patient.
Yeah.
Now I can't do that.
Yeah. Well, you probably could.
But I can visit. I can visit a hospital, and so I would say going back to your people is something that I think grounds you. And sometimes you just have to find one small thing that you were able to make a difference.
Yeah.
And know that those small things add up.
They do.
And I certainly think that every one of us
can find those.
Can find that.
Yeah. My worst day that I have, I will walk over to the hospital, meet the people. It feeds my soul, right? Talk to individuals, stop by the chapel, say a prayer. Those are all important things. I think faith in my journey, and I know it's in yours as well, is very important. We can't lose sight that there's things we have to cling to during these type of tragedies in our lives. But being prepared is important, and you've given us some great perspective today of how we can be prepared for workplace safety and be prepared for if there's a violent encounter. So thank you for your perspective today. It means a great deal to us. Congratulations on the work you're doing. By the way, 2-year anniversary that you celebrated, right?
In May.
In May. So very awesome. So thank you for all you do for our chief nurses and for our hospitals, rural and big, because you go everywhere, and just being that advocate for nurses, something that we needed to do. I'm glad you identified it. So thanks for joining us today.
Thank you for having me. It's a privilege to serve our Michigan hospitals, and it's a privilege to be here with you.
Well, thanks, Amy. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of healthcare every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you subscribe to the show so you never miss an episode. Until next time, remember, Rural Health Strong.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.